Dr. Waleed Riad works as a consultant anesthesiology and interventional pain. He's a physician at the Danat Al Amarat Hospital in Abu Dhabi, in the Emirates, of course. He also serves as an adjunct clinical professor of anesthesiology at the Khalifa University in Abu Dhabi. He got a long experience in the field with multiple certifications. He got MBBCH and the Master of Science from Alexandria, Egypt. Then he got the PhD from the Al-Azhar University in Cairo, Egypt. As he was working in Saudi Arabia, he got the Airport of Anesthesia at the King Saud University Fellowship and Saudi Board. Dr. Waleed moved to Canada, where he got 3 more fellowships in ambulatory anesthesia. Preoperative medicine and interventional pain from the Toronto University. For the last few years, the main focus of Dr. Waleed's work is the interventional pain management of obstetrics and gynecology. He is the founder of this very specialized unit in the Cornish Hospital and was able to successfully manage thousands of patients.
Thank you very much.
Thank you for coming.
Thank you very much. Thank you very much, Mr. Chair. Thank you very much. Thank you very much. So, my talk will be a little different from that. We are all pain physicians, we are trained as pain physicians, but majority of us are not touching any pregnant patients. Okay? Any of us will see a lady who's like this, okay? Go home, go for therapy and come after 9 months. This is usually typically what we do. I landed in an obstetric hospital where I have to deal with this kind of patients. So my topic, which Dr. Amar asked me to give, is my thought about how we are dealing with this kind of patients. So it's not the standard pelvic pain that you are going to hear. It's a little bit modified with my thoughts and experience in this field. So I'm going to touch some of the procedures that we are commonly do for these kinds of patients. Some of the procedures may be known, some of the procedures that we are doing a little bit differently, and some of the procedures you never heard about it, and I'm going to explain. I hope I will be in time. Okay. So all of us are aware about the ganglion bar. This is all of us. We know ganglion bar block. Any physician here understands what's ganglion bar block. This is a sympathetic ganglia. This is a sympathetic ganglia present here, and it is used. It is the last sympathetic ganglia in the bone. So usually our indication, all of us will know that ganglion bar indication is acoccygemia. This is actually not correct. Okay, there's multiple indications to do a ganglion bar block. Any pelvic pain, it can be sympathetically mediated and neurologically mediated, can be treated with a pelvic implant. Any non-malignant pain procedure, like endometriosis, interstitial cystitis, chronic prostatitis, can also be treated with a ganglion bar block. Any malignant procedures, provided that the way for the injection is clear and no metastasis in this area, can be done. So usually prostate cancer, cervical cancer, we have a lot of cervical cancer patients, we are doing this for them, and also with the patient with cancer, colon metastasis in the sacrum. This area is very, very painful, and the pelvis is very painful, very severe pain. Okay. Medication is not working, even narcotics are not. Last higher dose narcotics not working, and it can be treated with very simple injection. It's very simple injection actually, but you need to know how to do it safely. Okay. And of course, coccygemia. So coccygemia is not the only indication to do ganglion bar blocks. There's multiple indications to do that. The technique is very simple. It's a very simple technique actually. You need to put the patient in prone position. You need to make, as we discussed in the morning, in the workshop, I already showed some of these tricks to others. You have to make the legs look inverted in order to remove the spasm of the glutei. And it depends on how big is your patient. If your patient is too big, you can take the trachea from outside with tape and able to see. You can use any kind of needle, starting from the regular hypodermic needle, which is 25 gauge, to spinal needle, depending on the size of your patient. There is multiple ways to put your needle into the ganglion part, but I think the most safest one is the sacrococcygeal or intercoccygeal spaces, as we discussed in the morning. Other techniques are there is a higher risk of perforation or rectal perforation because you don't have any access to bone to guard you. And as you know, we all know that we love the bone. Bone is our safe friend. If you go and so paracoccygeal space, you don't have bone, and you are going to maybe in some patient you pierce the rectum go into too much deep. So what is the technique? As I saw in the morning, we can do under fluoroscopy and we can do ultrasound, as I explained to some of our colleagues in the morning. We can do through ultrasound, we can locate our area, but we can do also fluoroscopy. And try to find the wide space. Why you are using ultrasound? Because you try to find the wide space. Sometimes you have sacrococcygeal joint is there, and C1, C2 space is there. So one of them is smaller, one of them is easy. Try to make it easy for yourself and go for the wide space and go through this one. This will never be seen by an X-ray. You can see it only by ultrasound. As well as if you are the angle, if you have osteophytes or ossification, you will not be able to see this with the X-ray. You'll be able to see this only with the ultrasound. So your ultrasound will help you. But it's not the ultimate solution. Still, you have to go through the joint and pass to the other side of the bone and inject your dye. And when you inject your dye, you'll be able to see the dye spreading like this. Okay? So this is half of ml solution, and even injecting more, you can see the dye is spreading more higher up. Okay? This totally confirms that the dye is behind the rectum, okay? And everything is correct, and this is the time you can do whatever you want to do. Okay. So for patients with non-malignant patients, you can inject local anesthetic and steroids as the first injection. And if it's painful, you can repeat that with radio frequency or cry. For malignant patient, you can use phenol or alcohol. In our practice, we use phenol because it's easier and safer and not painful to the patient. This people has a lot of pain. So we try better to use phenol if it's available. Phenol 6% is available, so we can do that. As I said, okay, if you look to this picture here, this is the beautiful ultrasound came here, okay? This patient here, in this area, it's very difficult to go through this joint without ultrasound because you will be always hitting the bone if you go like that. You will not be able to do like this, okay? You will be hitting the bone, always hitting the bone. You will not be able, unless you change your direction. And you will not know that your direction is you have to tilt your needle upward to go down, unless you can see this under ultrasound. With the X-ray only, you will be hitting the bone for a long time. I have many patients which is referred from my colleague in other hospital that we need to do ganglion bar, but we fail to do ganglion bar. It's too painful. And this was the reason. In all of them, this was the reason. That the joint is not a straightforward. The joint is looking downward, and you have to change the direction of your knee. I will not be able to see this except if I do an ultrasound. So that's what we inject, as I said, okay? After confirming either phenol or local anesthetic. Okay, so we have to be cautious that once you are majority are anesthesiologists and you know that you are doing epidural, once you because of resistance, you stop. Here exactly the same. Once you pass the bone, there is changes in resistance, you need to stop. Don't go forward, okay? Because if you go forward, you are going to go into the deep part of the pelvis, and most thing that you are going to entitle is the colon and the rectum. And you can see here, the rectum is actually here. So you have to go as much as you can posteriorly. Okay. So the common complication for this procedure, the most common complication is the rectal perforation, okay, and also complication related to the needle injection. Medication can inject it as well. Okay. So this is in brief what I think that you need to know about that ganglion involvement. The second most common thing that many of us want to do, these patients refer to us mainly from the neurosurgeon. Before surgery, they want us to do a selective S1 nerve root block. So we can do this very easily, okay? Usually, typically, we do this for a patient with sciatic pain. So some of my surgeon colleagues said, okay, we are going to do surgery, can you do a selective nerve block? Because they want to make sure that once they remove the disc, the patient will get relief. So how can we do this under X-ray? So X-ray is, this is what everybody do, that we need to do the medication into ventral part of the anterior space. We put the patient in the prone position, we put a pelvic support, we square the S1 vertebral body, so means that it's a one line like this here, okay? And try to find the S1 foramen. Okay. So we have to go to the posterior part. So if you look here, there is a lot of foramina here. Okay, which one is S1 foramen? Especially if the patient has a lot of gases, it's very difficult actually to locate the foramen. So the posterior foramen, as we all know, the smallest one. Okay, it's usually under the pedicle. It's at the level of upper part of sacroiliac joint. This is how can you locate the S1 foramen under X-ray. Then, if you are not able to find it, you tell to the ipsilateral side. If you are not able to find it, you locate the other foramen on the other side and make the same level. We try to find the place to go inside the foramen. Okay. But easier if we use ultrasound. So we can locate the foramen under ultrasound. As I show in the morning, okay, you can put the probe either transverse or the vertebral space over the sacrum, and in transverse here, you can see the foramen. And in the longitudinal view, still you can see the foramen, okay? So you locate the foramen by ultrasound, it takes only 2 seconds to locate the foramen. By X-ray, sometimes it takes 5 minutes, and we are not 100% sure. We have to put the needle and go lateral view to make sure that we are inside the foramen, okay? Here it's very easy, okay? It's 1 minute, less than 1 minute. You put your needle, remove the ultrasound probe. Now you can go inside the foramen, or you can go on X-ray. At least you locate the space where is you put your foramen. Simple, and easy. Then you can advance your needle inside the foramen. If you look here, okay, sorry. If you look here, you have a big foramen here. This is not the correct one. Okay, the small one is the correct one. Okay, sometimes you miss this small one. The small one is the posterior, the big one is the anterior. So sometimes you miss the small one and you find the anterior. You try to go in, you will not be able to go in. There is no foramen, it's anterior. You cannot see it. Okay? You will not be able to go through this one. And if you find the foramen, you need to go into the upper part because the nerve is lower part. The upper lateral part of the foramen, where you put your needle and goes inside the foramen. And if you do so, you can go to lateral view and inject your dye. This is the picture that you are going to get. So it's very simple also to do as S1 nerve block if you combine both. You combine fluoroscopy and ultrasound. Okay? Ultrasound alone is not enough, okay? Because you are not able to prove to your surgeon that yes, I did S1 foramen and it's working. I want to insert the epidural space and I inject the medication in the ventral part of the epidural space. You will not be able to prove that, okay? With the ultrasound. But the ultrasound is going to help you with location of the foramen, easy, fast, and then you confirm with the fluoroscopy. Sometimes fluoroscopy alone is also difficult. So I always say that combination of both ultrasound and X-ray will make up life of pain physician is much easier. The third block I'm going to speak about is the sacroiliac joint, and you can see if I put a sacroiliac joint, I didn't put this picture only, okay? Because this is not the sacroiliac joint alone. This is also the sacroiliac joint, okay? So the sacroiliac joint is not only bone. The sacroiliac joint has a lot of supportive ligament, and sometimes, or not sometimes, the majority of the patients with the sacroiliac joint problem have a problem of sacroiliac joint ligaments. So we call sacroiliac joint dysfunction, not sacroiliitis. Okay. So for the intra-articular part, how we can do sacroiliac joint injection? We can do with fluoroscopy and we do with ultrasound. Fluoroscopy, I think we all know how to do under fluoroscopy. Okay. you put the patient in the prone position, you put the patient straight, okay, you make the lumbar, take a lumbar lordosis, do an AB X-ray, locate the lower 2 centimeters of the joint, and inject. You can make a ferritin or not, you need to have the joint line as much as crispy as you can, and you need aim for the medial part of the joint, like this, okay? So you can put your needle like this. Okay. And this will, in the AB view, okay? Then you can rotate to see the needle in the lateral view. Usually we use a spinal needle for that, cerebral spinal needle. And if you want to confirm, you can confirm with arthrogram. You inject 0.5 to 0.25 to half cc of Omnibec. And sometimes you need to confirm that, but sometimes if you do this and you are actually outside the joint, okay, you are going to make the picture more difficult and you will not be able to see the joint anymore. Number one. Number two, if you inject the dye, okay, the joint will take 3 to 4 ml maximum, and you are taking half of ml of the solution that you want to put, fill it with contrast. Okay. So is that debate to use contrast or no contrast in these patients? Or you can use an ultrasound for location of the sacroiliac joint. And location of sacroiliac joint, as we show in the morning with our colleagues, it will take only like 10 seconds to locate the sacroiliac joints. Okay, it's safer. Okay, it's safer and it's easier and faster. I don't need to wait for the CR machine. And if you don't for frequently, you'll be able to see the joint exactly. So there's 2 ways, as we discussed in the morning, to find the sacroiliac joint. You can count from down through the foramina, as we showed, from S4 foramina, you go S4, S3, S2, S1. And the joint will be between S1 and S2, or you can come from up from the lumbar vertebrae and go down and locate the S1 foramina and go laterally, and you'll be able to see the sacroiliac joint. And the direction of the injection as in the arrow from medial to lateral. Don't try to inject from lateral to medial because you will not be able to go inside the joint itself. This will be impossible because the area will prevent you. You can go out of plane if the patient is thin. Sometimes you can do this out of plane. It's no problem. This is how I do it as under ultrasound. You can see the needle coming from right to left, from medial to lateral, and you can reach actually to the joint here inside, and you can inject inside. This is if I am interested to do a sacroiliac joint injection, which is was documented by sacroiliitis, okay, by X-ray. But sometimes you lose this, okay, and the patient does not get any relief. Say, oh yes, my pain may be 10%, 13%. Clinically, examination is sacroiliac. So where is the problem? Okay. The problem is like that intraarticular injection is not enough sufficient for case of sacroiliac joint injection. Because why? Because the joint has a lot of supporting ligament, and the majority of the people have a laceration or sprain of the joint. The joint have multiple spaces, multiple ligament support. We have 3 joints from the back, 3 ligaments from the back, 1 ligament from the front, and 1 ligament from the both anterior and posterior. From the posterior, we have interosseous ligament, we have posterior sacroiliac ligament, and we have sacrospinous sacropubis ligament. And we have anterior sacroiliac ligament, and we have iliolumbar ligament. And iliolumbar ligament, it has an anterior part and has a posterior part. This is in detail the iliolumbar ligament, okay? It originates from L5 vertebra, some people say from L4 vertebra, and inserted into the, from the transversal and goes to the iliac crest. And it's one of the main reasons of stabilization of the joint is iliolumbar ligament. Iliolumbar ligament is the cause of anterior hip pain. So the patient sometimes present, you wrote many presentations for sacroiliac joint. One of them is the groin pain. If the patient have a groin pain, okay, and you treat her or him And say the back pain is gone, but the groin pain is still there, it's the time you need to inject the iliolumbar ligament. This is how it looks under ultrasound. This is the iliolumbar ligament here, okay? And I injected separately, and I injected in 2 or 3 places, here, here, and here, separately, and inject the iliolumbar ligament. If the patient comes with groin pain, so if you do sacroiliac joint injection alone, pain will not go, okay? You have to combine with the iliolumbar ligament. And there is a lot of work now on regeneration or therapy for the iliolumbar ligament for improvement of the stability of the joint. So if the patient tells you that I have a crepitus sound with movement, okay? Crepitus sound means that joint instability. Joint instability means the access of the ligament, okay? Intra-articular injection of sacroiliac joint is not enough. You have to combine with injection of the ligaments that support the sacroiliac joint. If you don't do that, you will not be able to inject in this area. You will get relief. So this is my thought about the intra-articular joint injection from my experience over the few years with obstetric patients. One of the obstetric drugs that maybe none of them is doing is symphysis pubis injections. So as you can see that it's related to pregnancy and delivery, okay? The ladies will get, most of you know obstetric pubis from the sport medicine. We are, I think, this is as a patient you are represented, this patient presented for us with the obstetric pubis, but very rarely we accept this patient with anterior pelvic pain following delivery. You can see here in the bone, the X-ray, you can see a lot of separation here. Same picture with ultrasound here. Here, this is the same bone, but no separation, but enlargement of the ligament called superior pubic ligament. So this patient presented to us with sharp anterior pelvic pain. The pain is in the anterior pelvic area, and it's motion-related disease. In the beginning, it's motion-related disease. After that, the pain present all the time. And there's also sound in this area. There's a patient with sound. I'm hearing a clicking sound in this area. Pain, of course, relieved by rest. If you examine this patient, examination is very, very easy. Their way of walking is different. Okay, there is tenderness of the symphysis pubis, positive treatment bear test, and positive fever test. And if you do ultrasound, it's very easy. You can see both separation of the bone and the ligament enlargement and torn. It's not okay to do X-ray alone and tell the patient that you have no problem, because many patients have no bony problem. They have also ligamentous problem. So you should be aware that there is these 2 kinds of disease. We have bone problem and we have ligament problem. And based on that, you can inject what the patient has. So the treatment, I speak only about the interventional treatment because of the time. This is patient has a bone separation, you can see that, and we are injecting inside the joint itself. We inject under ultrasound out of brain. You can see my needle here coming in this way, okay? And we inject out of the brain, local anesthetic and corticosteroid for the first time. Okay. And this is up, you can see this before injection, this after injection, the area is closed. So we have restored here problem. And you can also inject in the ligament itself. So as you can see here, this is the ultrasound, and you can see here the ultrasound. The needle is coming this way. We can inject right side and left side of the joint. Many of these patients, they come have this procedure 1 or 2 weeks before delivery because they have unable to open both themselves in the certain position. So this injection will help them to put themselves in the certain position. Very simple injection, take about 2 minutes. In the last 2 minutes, I'm going to speak in very short about the performance syndrome. I'm not going to go through details because we explain this in the morning, but it's one of the common problems that we always see in our clinic. We explain this in the morning. People will present with low back pain, body pain, hip pain, and of course, plus or positive sciatic irritation. It's not difficult to locate the performance syndrome. Okay? You locate the origin and insertion. So it originated from here, sacral, and it ends here in the greater trochanter. So the muscle is this area. If you put your probe like this area, you are able to locate the muscle very easily. You will be able to locate the muscle very easily. If you locate the muscle, okay, you ask the patient to abduct the hip, abduct the hip, you'll be able to the muscle moving with the hip abduction, okay? As you can see in this video. You inject intramuscular. It's an intramuscular injection, keeping in mind that you have to avoid the sciatic nerve. This is the needle inside the muscle, avoiding the sciatic nerve. So this is, if you want to know more about pain education, you can visit my YouTube channel. This is my YouTube channel in English. If you scan the barcode, you can reach the channel, okay? I have another channel for patients. This is in Arabic. You can scan also the barcode. You can reach to the channel. And of course, a lot of video on my Instagram if you want to know in plain English for your patient. And thank you very, very much.
Thank you very much, Dr. Waleed. This is very interesting stuff. And there is time for a few questions. Is there anyone in the audience who want to ask a question to Dr. Waleed? Well, before he's there, I'd like to ask you a question.
Yes.
I think diagnosing sacroiliac joint pain, I always find it during my practice very difficult to differentiate between the iliolumbar ligament and the joint itself. And as I am aware that many surgeons are doing fusions and major operations without a good diagnostic tool, it was my impression that the iliolumbar ligament was the most important cause of so-called sacroiliac pain. Can you agree with that one? And can you differentiate before your procedure?
So actually, it's a clinical examination. So iliolumbar ligament, you go through the interventional process of L4 and L5, you put your hand there and go down to the iliac crest. This is the course of sacroiliac iliolumbar ligament. And you go through it. The ligament actually, if the patient has a little, it's very tender and you can feel it. You can feel the ligament itself. And you ask the patient, you do an hip abduction, favor test, the pain will come in front. So this is iliolumbar. And very easy, we do diagnostic test. We inject this under ultrasound, we inject this ligament only. It's very easy injection. It's like 2 ml, and how is your pain now? It's pain is down. So diagnostic block for this iliolumbar ligament. And at present, there is a lot of work for injection of PRP into iliolumbar ligament itself. There's a lot of work for that.
Okay, thank you very much. And then we have a question.
Yeah. Excellent presentation, Professor Riad. Just quick question. Two questions really. Number one, do you advocate the use of at least a single shot of antibiotic before ganglionic bulb injections? And secondly, given the potential for contamination of the disc, do you use a needle-to-needle technique?
So I hear his first questions, okay? So I don't inject, I use antibiotic, but usually we prepare the patient. Usually we prepare the patient. We ask the patient, so tomorrow we have ganglion implants, okay? I give them anti-flatus 1 day before and ask, two days before, and ask them, last meal tomorrow is 4 o'clock, okay? So there will be a lot of gases in the sacrum and the rectum, and it will be far from me. So usually I do like that. 2 days of anti-flatus and last meal, solid food, 4 o'clock, 1 day before the procedure. Same like our colonoscopy colleagues prepare, I also prepare the rectum for that. So I don't use antibiotic because I feel that it's no need. What's the second question, sorry?
The second question was, given the potential for contamination of the disc space when you withdraw the needle, do you advocate the use of, as some people have done, of using a needle-through-needle technique?
Okay. Contamination with what?
Well, because your needle has pierced past the disc into the, not in the rectum, but in the prerectal, postrectal fascia. So when you withdraw the needle back, there's been some comments about whether we can contaminate the disc.
No, this is very
You
small.
just-
Actually, I'll tell you what I'm doing also. When I'm coming back, I inject inside this half cc of local anesthetic because to decrease their pain. Because many patients after that will come, everything is good, but I have pain here. Okay, so when I'm coming back, I inject half cc of local anesthetic inside. It will build usually resistance, but I inject half cc inside before I come back. So no, I don't do.
Thank you. One last question, please.
Professor Waleed, if you have intractable coccydynia, you will consider phenol or alcohol injection?
No, if I have very severe, okay, I'll first see if it's a fracture, mobile, or I'll check mobility. If it's too mobile, I can do mobility under ultrasound. I can see it's mobile or not mobile. Okay? If it is too much mobile, I first send to my surgical colleague, see if he is interested to do anything or not. So this is the first thing I do. If it's totally mobile, because if it's totally mobile, nothing is going to work. So usually he said, no, I will remove it. He will remove it. He said, no, we're not going to remove the coccyx. Okay, so I'm going to deal with it. Sometimes the patient, every time he said, there is a sound. There is a sound every time. It's too much mobility. Too much mobility is very difficult to treat. Okay? So first ask the surgeon. So we have a surgeon colleague. We are all cases going between us. He said, can you see this? He said, no. He said, yeah, I will do surgery. This is too much mobile. So he will remove it. So,
Thank you very much again.
thank you.